That I'm just hitting some highlights. The rest of the content in the chapter is still your responsibility to learn, okay? I never know how to work this machine. Okay, so the normal newborn, I threw this in here. This is probably a little review for you. This is just for IM injections on babies, okay? We do them in the thigh, left or right. The vastus lataris is that kind of muscle on the side here, or on the edge, and the rectus femoris is this big one in the middle, okay? So when you do your IM injections, kind of the middle area of these muscles, either one of these, okay? So you really want to be lateral or side-ish, okay? Because you've got this big old nerve that runs right down the center there, and we don't want to be hitting that. And you remember with IM injections, you don't have to aspirate, at least for babies. I don't know about big people. But for babies, we don't need to aspirate, okay? You just give it. Okay. Now, we're going to talk about circumcisions. So, some facilities, the pediatrician does the circumcision after delivery in the hospital before they're discharged. Some facilities, they wait until the baby comes into the clinic for the 2-week appointment. Why you ask? It's a reimbursement issue for the physician. The one criteria, not the one, some of the criteria for even doing a circumcision is the baby has to avoid it. So if they do it in the hospital, they have to wait till after the baby pees. Sometimes the baby pees right away. Sometimes the baby takes 24 hours to pee. But they got to wait for the baby to void. And the other thing is the meatus has to be at the tip of the penis. Okay? He can't have hypospadus or epispadus. Hypo being on the bottom of the penis, epi being on the top, and or the top side or the bottom side. And it can be, that meatus can be anywhere on the penile shaft. Doesn't just have to be in the head area of the penis. It could be anywhere, up and down, that whole deal. Okay? But anyways, and if that's the case, I mean, there's still a communication to the bladder through that opening, wherever it is. He will not be able, that child will not be able to have a circumcision if he has one of those spadias, and he will need a referral to a surgeon, and they will have that fixed. And then if they want circumcision, then they can do it at that time. But there's two different kind of circumcision. One's called the Gomco clamp circumcision, and that's the one we see here, or part of it. And the other one's called a Plastival, and we'll see that here in a minute. Now, it's just physician preference, whichever one they use. Okay. Now, with the Gomco, they take little forceps and they just clip right on the edge of the foreskin, and then they take this, I can't remember what this little thing, it's just a little metal stick basically, and they just kind of go down in there and break those adhesions away, okay? And then after they get those adhesions broke away, then they take this bell thing and they wedge it in there and put it right over the head of the penis, okay? Now some of them have this tie deal, okay, where they tie the foreskin up on these little ledges here at the top. Some of them don't have the tie deal, and that's okay. Some of them are just a metal clamp with those ledges at the top. I should probably use my cursor so other people can see. So, oh, this doesn't get my cursor on there. Oh, crap. So those ledges there at the top, this clamp slides on and hooks under those ledges at the top. And that's going to create the torque and pressure right here. at the where the scalpel is showing. It's going to create torque and pressure there to kind of smash that skin there, okay? And so they're supposed to leave this on for 5 minutes, okay? So that when they cut around here and cut that skin off, it's kind of, all the vessels have kind of sealed, closed, and clamped off, okay? So they cut the skin off, and then they release the clamp, and the problem with this circumcision is, it's not really a problem, but I think it's a little harder for the parents to take care of, because this is just, the head of the penis is basically like raw skin, like you tore the skin off of a blister, okay? So we slather it in petroleum jelly just so it won't stick to the diaper. We don't put ointment on it, we don't do nothing, we just let it heal, but we instruct the parents to slather that in petroleum gel or Vaseline or whatever, just to keep it from sticking to the diaper until it heals, okay? The other problem with these is if they don't hold that clamp on there for 5 minutes, what's the big deal? Well, we wouldn't have kind of clamped those vessels off, so it continually bleeds, and sometimes it bleeds too much, okay? And we have to actually take gauze 2x2s or 2x4s and hold it on there, hold pressure on there until that stops bleeding, and then we have to continually reassess it, you know, at frequent intervals to make sure it doesn't start bleeding again. The other thing that it can do is the skin on the shaft falls down like a sock. Okay, so if we're working with a physician that's really impatient, we just really need to encourage them to wait the 5 minutes before they release that clamp. Okay. Now the next one, which is my preference, is called the Plastabel. It's this little plastic cap, okay? It has a handle on it here. So he does the same thing with the foreskin. He puts the little clamps on it. He takes that little poker deal and releases the adhesions. He slides this clamp on to the head of the penis, and it has a little lip here that he ties a string around, so he's not like tying onto the shaft of the penis. It's the lip of this plastic clamp is down here underneath the skin. He ties that string on as tight as he can, and then he trims off the foreskin, okay? The plastic cap stays on, and he breaks the handle off, and now there's a big hole there for the child to void through, okay? I like these because there's very little bleeding and nothing. You do nothing to this thing. You leave it alone. The only thing you do to this is if it gets stool on it, you clean it off with a wet cloth. You don't put ointment on it. You don't, nothing to it. You do nothing. And then when that finally heals, then that cap and that string will fall off. Done. Very sweet and simple. Okay, so there's your circumcisions. Now after the circumcision, if you're in the hospital, you can't let this baby go home until they voided after a circumcision. Okay? And then if they're doing this in the clinic, then you need to instruct the parents that if this child hasn't voided within 24 hours, and I would give them 12 actually, just to not push it to the end of the limit. 12 to 24 hours. If the child hasn't voided, they need to come back in. Okay. Now the way they medicate for this is one, we do Sweeties now. Is everybody familiar with Sweeties? It's a 24% sucrose solution. Okay, and you know, you just give a few drops in the baby's mouth and put a pacifier in the baby's mouth. And then it works kind of on the morphine receptor, or on the pain receptors like morphine, okay? It soothes and calms and it kind of puts baby into a little euphoric coma, okay? No coma, but the baby just, you know, just lays there. And then we use lidocaine, okay? And we can only numb up this top portion of the penis. We can't numb up down here because there's too many vessels and nerve innervation that we could possibly damage. So the underneath, this little area underneath of the peanuts is not numb, just the top, okay? So hopefully the sucrose solution is enough, and sometimes babies completely sleep through this procedure. Sometimes. But sometimes they scream the whole time. And mostly it's because we strap the legs down. So we put them on a little board that has like a indentation of a baby, and we strap their legs down with little Velcro straps. And we let their arms be in here because that makes them feel a little better. But usually by the time we get them on that cold plastic hard board and strap their legs down, they're screaming already. So babies don't like to be stretched out. All right, so here's what a Plastibell circumcision looks like. There's the plastic cap, a big old hole, and you can see the string is on there. Okay, so that will heal and just fall off and look very nice. All right, any questions about circumcision? What do babies have to do before you circ? What do they have to do afterwards?
If the second method is so neat and tidy, why would they even do the other one?
Well, yeah, why would they? But some physicians that have been, you know, sometimes how you try something for the first time and you get used to it and you really like it, and then you're introduced to something else, and even though it might be better, you're still used to the old way, so you stay with the old way. Yeah. And they're quicker, like you don't have to wait. You put that cap on, you tie the string, you trim off the foreskin, you go about your business. They're very quick. Okay, just going to hit a little bit on breastfeeding. Everybody, you know, you've heard breastfeeding Nazis and, you know, people who, breast milk is the better of the options for feeding babies. It has over 200 components, including stem cells. Okay, you can't get stem cells in formula. Okay, high lactose content, lots of antibodies. Formula milk tries its very darndest to replicate breast milk, and it can't. It just can't do it. But anyways, with all the things that are in breast milk, these are the benefits, and these are not just benefits right after delivery. These are long-term benefits. These could be lifetime benefits, depending on how long mom breastfed. Okay, the longer mom breastfeeds, the more their risk is reduced. Okay, so type 1, type 2 diabetes, childhood cancers, obesity, asthma, SIDS. When we do painful procedures, if it's possible, we like baby to be latched onto the breast and nursing because it helps with pain. Okay. So they have less respiratory and GI problems. It says GI infections, but GI problems like constipation and diarrhea, you don't have those problems as hardly at all with breastfed babies. It decreases the incidence of necrotizing enterocolitis. So if you have a preterm baby that is susceptible to necrotizing enterocolitis, do we all remember what that is? That's where the gut dies. Okay. Preterm babies very susceptible to NEC. They call it NEC. Their gut is just not mature enough to process foods. So if you do end up putting foods down a preterm baby, I hope it's breast milk, because breast milk is so much easier to process. So they have a less chance of developing NEC. Otitis media, you know, because of the antibodies, but the other thing that they're thinking is because the way babies are positioned when they're breastfeeding helps keep the eustachian tubes drained. Okay, that might be one of the reasons. So allergies, all these benefits to baby. It helps them develop their own natural immunities. They get higher antibody level. Okay. Now, benefits for mom is, so moms sleep better. Well, how can you put that together with breastfeeding when you're breastfeeding so often, and sometimes it takes a little longer to get baby latched on and get going. But their studies are showing that moms are sleeping more and sleeping better when they breastfeed their babies, okay, for whatever reason. So all these energy, better mood, you get back into shape quicker, and it can be used as birth control. Now, I don't know if you've heard me say, it's not a reliable method for birth control. The one thing that makes it a not reliable method is the mom has to be breastfeeding every 2 hours, 24/7, for as long as she wants to be protected. Okay, so 3 months, 6 months, are you going to be breastfeeding every 2 hours? Exclusive breastfeeding, okay? So the baby can't be getting any other nutrients, or the baby can't be suckling on a pacifier. It has to be all mom for the body to keep her in protection from pregnancy, okay? So it's not reliable. Like if you go 3, 4, 6 hours, okay, if you pump, even pumping can throw you off here, okay? Because pumping is, the breasts feel the difference between pumping and a baby sucking, okay? So it's not really reliable. So I don't like my patients to think that, oh, I'm breastfeeding, I'm good. Well, you might be, you might not be. So at 6 weeks postpartum, they put them on the mini pill, which is a progesterone-only pill, and that won't interfere with their breastfeeding, okay? All right, so fosters baby's brain growth, and their studies are showing that people who breastfeed have a higher IQ than people who don't. So all us bottle-fed babies are just dumb. No, we're not dumb, but I mean, okay. So moms are at reduced risk for cancers, and again, this is related to how long she breastfeeds. Diabetes, heart disease, and stroke. So these breastfeeding benefits, some of them are immediate, like postpartum depression, but some of these are lifelong benefits, okay? Hypertension, osteoporosis, all these wonderful things. Mom is at reduced risk if she breastfeeds, okay? And the longer she breastfeeds, the greater her reduction in risk, okay? And then the psychosocial advantages, bonding, all these great foo-foo things, okay? And of course, anywhere you go, you have your feeding, okay? You don't have to store it. It doesn't cost you any money. You can just whip that boob out right in the middle of Walmart. Okay? Disadvantages, okay? Nipple tenderness. Now, nipple tenderness is kind of something that happens, within the first 24 to 48 hours of breastfeeding, because your nipples are not used to being breastfeeding, okay? But that should stop. If that continues after a day or two, then we have a latch problem. Or we have mom creating trauma when baby's breastfeeding and she pulls the baby off her breast. Okay, that can cause trauma to her nipple. So if she's having nipple tenderness after the first couple of days, we need to figure out why, because it could be a fixable problem. But the first couple of days can be pretty intense, especially if the first couple of days she's latched on there wrong, and not only does she have sore nipples, but she has cracked, bleeding, blistering nipples. And even to have a gown touching her nipples is painful, okay? So this is why people might stop breastfeeding, is because it's so painful. But we can fix that. We have the power. So the other thing is leaking. So you're walking around in Walmart and some child is screaming and you're just going to ooze from your breasts. And if you don't have pads on, everybody's going to know. So embarrassment about breastfeeding. So There's a lot of products out there. There's things that have like, the hair bands gals put on their head, and they can put those through stitch those through a blanket and put it around their neck, and now they have a drape for breastfeeding in public. But this is kind of a public thing, and there is a huge part of the population that is very unsupportive for breastfeeding and very unsupportive for it being done in public. So we need to change the thought processes. But anyways, it might not be supported by the family. Like mom and grandma didn't breastfeed, and this is not okay. I mean, some families, some cultures. As a matter of fact, I think it's the Hispanic culture, maybe some Asian cultures. The colostrum is dirty and yucky, and the baby doesn't get it, and they don't start breastfeeding until 2 weeks of age. Okay, so there's some things going on. Okay, feeling tied down to the demands of breastfeeding. So if you go back to work, what are you going to do? Are you going to bottle feed your baby, or you're going to continue to breastfeed? If you're going to continue to breastfeed, you really need to start pumping. So you need to start pumping at work. And does your work support you taking breaks and going to pump? Okay. And then, family members feeling left out because they don't get to feed the baby. Well, they can get up in the middle of the night and change the baby's diaper and bring the baby to you, and now they're part of the feeding process. Okay?
Just the other end.
Yep. And then take the baby back to the crib. Okay, so there's diet restrictions when you're breastfeeding. So, finally my baby's born, now I can have a glass of wine. Well, yeah, you can have a glass of wine and still breastfeed, but there's a lot of diet restrictions. And women who like herbal supplements and herbal teas, they have to make sure those herbs are not, one, going to dry up the milk, or two, cross into the breast milk and maybe cause some sort of problem for baby. Okay? Limited birth control options, so the progesterone only options. And then of course medications, just the same kind of with alcohol is, and herbs or natural things, they need to check with the pediatrician, okay? And the pediatrician should know what is safe. Now, the one big, there's a lot of medications that she wasn't able to take in pregnancy, but she can take when she breastfeeds, okay? So we just need to find out what crosses over and what doesn't. But one of the big medications that's a huge problem with breastfeeding mom is over-counter medications. It's over-the-counter. It's safe, okay? But if she takes any decongestants over-the-counter, she's not only going to dry up her sinuses, she's going to dry up her milk. Okay, so we need to educate these moms. Anything they put in their mouth, they need to check with the doc, even if it's over the counter and even if it's a natural herb. Okay, so these people cannot breastfeed. Okay, people with HIV, TB, people who use drugs. It says here smoking. We have lots of women who smoke and breastfeed. But thank goodness, because if they don't breastfeed and they were a smoker all through pregnancy, then they're going to have a cranky baby for about a month, because he's going to go through nicotine withdrawal. Okay. All right. Any questions about the wonderful aspects of breast milk?
But, how would Mexican babies be fed then if they didn't breastfeed
Formula.
for 2 weeks?
All right, so one of the big things after delivery, if you guys work in a postpartum unit, there is a diagnosis called BFI. Does anybody know what that means? Breastfeeding issues. So pick the other assignment. Or call the lactation lady. But anyways, breastfeeding is a natural thing, right? But moms who've never breastfed, it's not natural to them. They have to learn. And babies who've never breastfed have to learn, okay? Babies, the studies with babies and skin to skin is these really breastfeeding gurus, they want you to put the baby skin to skin. and they don't want the nurse to come in and grab the baby's head and grab the woman's boob and introduce them. They don't want us touching the baby. They want the baby to naturally start like henpecking and then sniffing and getting to the breast on their own. That's the natural process. But we don't have time for that, so we have to intervene because we want babies to nurse within an hour, okay? Because we're smarter than nature. Anyways, so I shouldn't be recording my
You're on a roll this morning.
smart comments. So we teach mom breastfeeding cues. So when a baby is screaming and crying, is that a breastfeeding cue? Yes, it is. Is it an early one or a late one? I will tell you it's a late one, okay? The babies will do things to tell you he or she's ready to eat before she starts screaming her head off. And those are called breastfeeding cues, okay? And the baby will put their hands and hit themselves in the face and try to lick their hands and try to suck on their blanket. They will turn their mouth to anything that comes close to their cheek. And if anything comes to their lips, they will try to latch onto it. They will lick their lips. They will stick their tongue out. They will do those kind of things. Those are feeding cues. And that's when it's time to feed your baby. But if you don't catch those, of course, a screaming child is another cue. But a screaming child most often will not latch on when you stick the boob down their throat because they're so mad. It's like they can't get over their anger when they've got the boob in their mouth. So now you need to quiet the baby and then try to get the baby to latch on. Okay? So we promote the early skin-to-skin contact. We breastfeed right away in the birthing room. Within an hour, we like to do that, okay? As far as formula-fed infants, you do that according to hospital policy. Formula-fed infants can feed anywhere from 2 to 4 hours, every 2 to 4 hours. It takes their body longer to process that formula that's in their gut, so they're not as hungry as quickly, and they tend to eat more on a bottle than they do at the breast. Some hospitals and community in particular is baby friendly. So what does that mean? Well, it's a program. Man, that is cold air coming out of there. It's a program, a national program that is trying to promote exclusive breastfeeding, okay? And the Healthy People 2020 goals are that X amount will be, a certain percentage will be breastfeeding after discharge, a certain percentage will be breastfeeding at 3 months, exclusive, and 6 months, and so forth and so on. And one of the ways to promote that is, or the way you make those percentages increase, is to be baby friendly and teach exclusive breastfeeding from the time of birth, okay? And part of the protocols for this are that we like babies to be skin to skin for the first 24 hours. Like if that's where baby lives for the first 24 hours, except when mom gets up to use the bathroom, that's where we want baby, okay? Your moms have to be willing to do this. You can't force this on moms, but a lot of moms are willing to do this as much as they can. The other thing is that we do not accept, the formula companies give hospitals huge boxes full of those discharge bags that have formula samples in them, okay? We are not to accept those if we're baby friendly, okay? So what if your mom doesn't want to breastfeed, she wants to bottle feed, what's she going to do? Bring her own. BYOB. Bring your own baby's bottle. Anyways, we can't have any pacifiers in the postpartum unit. That's part of the baby-friendly criteria. No pacifiers. If your parents want a pacifier, they need to bring their own. Now that pacifier rule does not extend over into the NICU. Okay. All right. And for breastfeeding, no formula, no water. Okay. 85% of breast milk is water. So babies don't need any extra water. The first 24 to 48 hours, there's this thing called cluster feeding. Babies can basically nurse for 5 minutes, 30 minutes later nurse for 5 minutes, 30 minutes later nurse for 5 minutes. or just be on the breast continuously, okay? That's fine, let it happen, because we used to be really big about teaching moms, don't let that baby on that breast for 2 to 3 hours. We're trying to teach baby their schedule. But the studies are showing that the more that baby is on the breast in the first 24 to 48 hours, the sooner her milk will come in and at higher volumes, okay? So that's what on demand is. Anytime the baby wants to be on the breast, let the baby be on the breast. I don't care if you just did it 15 minutes ago. Let baby on the breast, okay? And then when mom's milk does come in, then we want them on the 2 to 3 hour schedule, okay? Feeding for about 15 minutes. Okay, start out there, okay? And determine your feeding schedule, your frequency, and your duration on what baby tells you. So if baby is feeding for 15 minutes every 2 hours for a week, that's the baby's telling you, this is what I need, and this is what we're doing. If the baby all of a sudden says, I fed for 15 minutes an hour ago and I'm hungry again and I want to feed another 15 minutes. And if baby does that for a couple of days, do that for baby for a couple of days. Okay? That's a growth spurt and baby needs it. And then you will start feeding baby for maybe 20 minutes. And then you'll hit the 2 hour mark. Okay? And then baby will feed for 20 minutes every 2 hours for a week or so. Here comes another growth spurt and now you readjust. So you let baby tell you when they need to feed. But don't let baby say, I'm going to wait 5 or 6 hours. Okay, babies have got to breastfeed at least every 3 hours. Okay, as far as breast milk is concerned, they need it that often. And as far as mom's production is concerned, she needs to be breastfeeding every 3 hours. Okay. Now, we do like to encourage nighttime sleeping. So if at night baby finds a period there where baby goes 4 to 6 hours without waking to feed, we like to promote that, after a couple of months, okay, for mom's sanity, for her sleep, but also when baby gets to that 4 to 6 hour mark of not waking up, mom will wake up because her breast will be full and she'll feel it and it'll wake her up and she will go knock on baby's door and say, it's time to eat, okay? So it's great after a couple of months if baby has a longer period to sleep through the night, okay? So formula-fed babies can eat about every 3 to 4 hours. It takes them longer to digest, process. One of the problems with formula feeding is when babies cry and they're upset, that doesn't always mean that they're hungry. But because of an inability to figure out what babies want, we've checked their diaper, they're not feverish, they're not congested, they're not having diarrhea, they don't seem to be in pain, they have a clean diaper. I've tried everything, I've rocked, I've walked, this baby is not settling down, I'm going to shove a bottle in their mouth. Okay? They are forced to drink. Okay? Whether they suck or not, they're forced to drink when a bottle's in their mouth. Because a little bit does, you turn a bottle upside down and a little bit does drip out. Okay? So they're forced to drink if that bottle's in their mouth. But there's a period around 6 weeks of age, the period of purple crying. I think I have the link on the main part of Moodle. But at 6 weeks, there's a period in which babies cry almost incessantly, without the parents, the family's ability to soothe that baby. No matter what you do, that baby is going to cry. Now, when they've done their studies and they've compared this 6 week normal period of crying with the hospital admissions for shaken baby syndrome, they correspond. So the hospital admissions, the diagnosis for shaken baby syndrome corresponds to the 6 week period of this incessant crying, okay? So as a nation, we educate our families before discharge on the period of purple crying, okay? We let them know because a lot of people don't know. I don't know what else to do. I'm going to throw this baby through the window, okay? I don't know what else to do. I'm tired, I'm exhausted, I'm bleeding out my eyeballs, I'm so tired, okay? And they take it out on this baby because they can't know what to do to shut this baby up. And so we want families to know this is normal. You're not going to shut that baby up. So put the baby in the crib, close the door, and leave the room. Let the baby cry. Baby's going to cry anyway. You're going to be holding the baby, walking around, trying everything to get him calm. He's going to cry anyway, okay? But at least he's not shaking baby. At least he's not been thrown through the window or put in the microwave, okay? Leave the baby in there. Leave the room, okay? Leave the room for an hour if you have to. Leave the room. It's not going to kill him to cry, all right? But anyways, I was off on a tangent. So people put bottles in babies' mouths to shut them up, and that's one of the reasons why we have heavier bottle-fed babies than breastfed babies, and we have babies with more dental problems. Because I just fed this baby, and I have to feed him again because he's screaming. So I'm going to prop the bottle, and I'm going to go do my things. Okay, so that causes dental problems. All right, breastfeeding positions. There's a lot of different positions. You can breastfeed a baby, and we teach the moms all these positions, okay? Because what it does is it helps empty the breast on like a rotating schedule, okay? So you have milk ducts and glands and stuff all around the breast, okay? If you're always breastfeeding in one way, then the way the baby's mouth, nose, and chin are, okay, those ducts are going to get emptied first and quicker and more often that are in line with the baby's nose and chin, okay? So if the baby's breastfeeding like this, okay, these, I know people recording aren't seeing, but these ducts on the breast are getting emptied. But these ducts over here on this side, they're getting emptied, but not fully, okay? So we have moms change positions. Football hold, the sideline hold, are holds that allow babies to empty the breast. So the football hold is, here's your baby's head. I know recording people can't see this. Here's your baby's head. Okay, here's your baby's feet. And you hold this baby like this and breastfeed. Okay? Now, the normal way is the cradle hold. Okay? This is how everybody holds a baby. A cross cradle is simply switching your arms. Okay? So I love the cross cradle. I don't care for the cradle hold, because if you got a mom with either big arms or big boobs, okay, I don't have really either, and so my baby's right there ready to nurse. Okay, she's right there ready to nurse. But if I had big beefy arms or big beefy breasts, you know, my baby's going to be sitting up like this, or I'm going to have my baby sitting down like this. Okay? So the cradle hold, that arm doesn't let you have very little movement with that arm to get baby positioned correctly, okay? But with the cross cradle, I can hold this baby and move this baby everywhere, okay? And I don't got any beef getting in the way, okay? And then the sideline hold this is great for dads who feel left out. Go get the baby, go change the diaper, bring the baby to me. Mom lays on her side, baby lays on his side. They are belly to belly on their sides. Baby is nursing off the bottom breast, right there, okay? Then you flip over and get mom's other breast, okay? So those are different positions that you can use, and teach moms before they leave the hospital to do that, okay? The other thing about with positioning with babies when breastfeeding is we want baby's belly facing mom's belly, okay? That way baby is looking straight on at the breast. The baby's head is not turned, okay? I don't like to drink my milk this way, and I'm sure the baby doesn't either, okay? The other thing is we want to make sure when we're positioning is we want the nose directly in front of the nipple, not the eyeballs and not the mouth, because we want the baby to extend their neck just slightly, open up that esophagus, open up that airway so they can breathe good, they can swallow good, and it actually puts less trauma on mom's nipple if baby's in the correct position, okay? And then the other thing that we need to check when we have mom's breastfeeding is everybody is positioned correctly, and we want mom as comfortable as possible, prop the whole hospital worth of pillows all around her so she can just be very comfortable. But the other thing, and baby's positioned right now, we need to make sure that baby latches on well, and this is the big problem when you have sore, cracked, bleeding nipples, is baby is not latched on correctly. So we want baby, we want baby latched onto the areola, not the nipple. Okay, if the baby's latched onto the nipple, then mom's done. She's going to be sore, cracked, bleeding, blistering. Plus, baby gets more milk when she nurses on the areola than when she does on the nipple. So we have our baby, we're holding our baby, and mom's holding her breast. She puts her hand in a C position and she holds her breast, and she takes her breast and she tickles baby's or rubs up baby's lip. Baby opens their mouth, okay, and then she shoves that baby on there, okay. She does not take her boob to her baby, okay. She doesn't bend over or stretch or twist or anything. She brings the baby to her boob, okay, and then we make sure that baby's latched on correctly. So their mouth has to be wide, their lips, it's very important, they got the tulip or the fish lips. So like this, okay? It's like this. Now a lot of times we'll have babies that do the top lip, okay, and curl the bottom lip under, okay? When babies do that, then they start really gnawing on the nipple, okay? So we need to make sure baby's lips are in that tulip or fish lip position and that they're on the areola. So if you've got a baby that latches on and they're not on the areola, you've got two choices. You can break baby off by having mom put her finger in the mouth and breaking the suction and then moving baby off her breast. Or you just tug a little bit on the chin skin of the baby and that pulls that lip down, okay? That helps if the lips aren't right, but if the jaw is not right, if baby is just on the nipple, you might have to pull harder to open the jaw so that they are now latching onto the areola, okay? So that's very important. And mom can look down there and, you know, you can show mom, look at the baby's lips. This is what your baby's lips need to look like. Look that your baby is on the areola, okay? And then we're going to start hearing swallowing, okay? So baby will suck, 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 suck for 5 minutes, and then baby will swallow, and then for 2 or 3 minutes, or moments. Then the baby will breathe, okay, and then the baby will get back, suck, 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 suck. And then the other thing I tell moms, if that suck, swallow, breathe starts lasting a minute or so, then you need to wake your baby up and get them back working, okay? Babies, you know, the first day or two, they're warm, they're snuggly, they smell mom, they feel comfortable, they fall asleep. Okay, we need to wake these babies up and make them nurse, okay? When mom's milk comes in, baby will definitely keep on the schedule. Okay, so for bottle fed people, the one thing we want to instruct our patients about is don't prop your baby's bottle and leave the room. And when you're feeding baby, make sure baby's head is up and they're not laying horizontally while you're feeding them, okay? And then we show them pictures of how small babies' bellies are. And right after delivery, the baby's belly volume is that of a marble. And we give them bottles that have 2 or 3 ounces in them, I think 2 ounces. Okay? And they're trying to get this whole feeding down this baby every time. And then they're like, oh, my baby doesn't like this formula. They spit up every time I feed them. Okay, so we need to instruct patients on, the families on how much is appropriate to feed these babies. And literally, it's 10 to 15 cc's of this 2-ounce bottle, okay? Anyways, so there's different preparations for formula. There's the powdered and there's the already made. We need to teach them about when the babies do drink on a bottle, that then the rest of the bottle is chucked. Okay, they don't save it for the next feeding. Okay, they can actually, if they feed the baby and within an hour the baby wants some more, they can use that same bottle. But generally they have to chuck the rest of the formula. Okay. All right, so there's all those different, what kinds of bottles, what kinds of nipples. No one, I guess, is better than the other. They have all kinds of fancy things you can buy and spend more money, but really it's all just about having baby positioned on, more vertical than horizontal, and not stuffing your baby with the whole entire bottle. Okay. So here's some cultural stuff about breastfeeding. Okay. Some women, they'll breastfeed for the first 6 weeks, maybe 3 months. Maybe when they start introducing food, they start weaning baby from the breast. Some women are breastfeeding at 4 years old. The baby's 4 years old. Okay. Oh, I don't have to do that. Okay. Oh man, I'm really hitting, I must be a breastfeeding Nazi. So we talked a little bit about nipple soreness, and the things that you can do for nipple soreness besides checking the latch is, if mom expressed a little bit of milk out of her nipple and then rubs it into her breast, that will help, one, seal off her breast, prevent infection, but there's soothing properties in the breast milk and lubrication properties in the breast milk that will help with soreness. We give out lanolin cream for moms to rub on their nipples if they're having problems. As long as they're not caking it on there, like you can scrape it off with a spoon. If they rub it on there and rub it in, they don't have to clean that off for the baby to breastfeed again, okay? There are shells that women can buy to cover their breasts, and then of course we want to have the lactation consultant see them to see if if we have latching or feeding issues or something. So there's all kinds of lactation support after discharge for mom. Same thing with cracked nipples. They're cracking, they're bleeding, they're blistering. You're going to do the same thing for them as you do for sore nipples, with the addition of maybe starting some analgesics, okay? Letting them take some pain medicine. Now, breast engorgement can be a big problem for breastfeeding moms. When we talk about breast engorgement, we usually think of the mom who is not breastfeeding, okay? She is bottle feeding, she's going to go home, her body is going to produce some milk, okay? And she is going to get engorged, she's going to be uncomfortable, and we need to just instruct, and then she'll dry up and it'll all go away, okay? But sometimes she can get so full and be so uncomfortable that she needs to do something to release that or to help that. And one of the things that she'll do is she will manually express or pump milk out of her breast to relieve the pressure, okay? For the non-breastfeeding mom, tell her not to do that, Why do we not want her to do that? Because the body's just going to make more and replace it, okay? So pain medicine, cold compresses. Okay, people say warm compresses. Warm compresses is going to dilate everything, more milk is going to rush in. Cold compresses are going to restrict everything, okay, and slow down milk production to the breast, okay? So cold compresses, tight fitting cups, not necessarily tight bras around the torso, tight fitting cups, even to the point of using an ACE wrap, okay? And then pain pills as she needs to. But for the breastfeeding mom, if she gets engorged, this can be a huge hindrance to actual latching the baby on and breastfeeding. Because engorgement is kind of normal, or fullness, until breastfeeding is established and the routine is established and everything kind of is going on a normal pace, okay? Fullness. But engorgement is different. Engorgement is literally, baby could latch onto a wall easier than to an engorged breast. It is so hard, baby cannot latch, okay? So for those moms, we want them to express a little milk from their breasts, just so it's meaty enough for baby to latch on, and then nurse, okay? And we want the woman to be nursing on a schedule. So new babies born, 15 minutes every 2 to 3 hours, okay? And that works out to be 8 to 12 feedings in a 24-hour period. And stick to that schedule, otherwise she's going to get engorged, okay? She could put warm compresses on her breasts before nursing to help dilate things and soften things. She could even get in a hot shower and soak her chest for a few minutes. And then after nursing, she can apply cold compresses to kind of settle things down a little bit. And then a good supportive bra, okay? Now, if she's having problems with engorgement, and engorgement isn't always the culprit, but she can end up with plugged ducts. And that's what it is. It's a duct that's full of milk that's plugged, so the milk has gotten very thick or hard, okay? And that creates blockage, it creates pain, tenderness, and sets her up for mastitis as well. But the way we treat plugged ducts is we put baby latched onto the breast with the nose pointing at the plug. Okay, so if the plug is at the center of her chest, then the baby's nose is at the center. If it's out the outside of her chest, the baby's nose is pointing to the outside. Okay, so we want the baby's nose pointing towards the plug because they create more pressure with the top of their suck than, and then so as baby is nursing, the woman is going to massage above the duct, through the duct, and towards the nipple. That will help, the sucking and the massaging will help work that plug through. And there's nothing dangerous about that plug, it's just milk, okay? So baby can ingest that. The other thing she can do is maybe put a little warm compress before feeding to help soften that up a little bit, okay? But that also sets her up for mastitis. So why do you get plugged ducts? Well, who knows? You could be breastfeeding in the same position all the time, and the other side gets a little, there's a little stasis there, and the other side gets a little thick and tenacious. So that's why we want her to change her positions. Purse straps or anything that kind of presses on the chest of the breast can kind of block that off, okay? Whatever. Just knowing what causes it just helps the woman to avoid that, to avoid plug ducts, okay? Oh, and then mastitis, I don't know why I don't have a slide on mastitis. So mastitis is an infection in the breast tissue, connective tissue, okay? It's painful, she'll have a fever, that place will be painful, warm, red, she'll feel like she has the flu, aches and pains all over. You know, we treat it like a flu, like fluids, bed rest, analgesics, and possibly antibiotics. And if she's on antibiotics, she just wants to be sure to tell her obstetrician that she's nursing so that he prescribes an antibiotic that is okay with nursing. Because back in the day, we used to pump and dump when moms had mastitis and on antibiotics. She would pump her breasts and then throw it away so that she could continue to make her supply until she could get baby nursing again, okay? So anyways, now we don't have to pump and dump. But as I mentioned before, alcohol and medications, over-the-counter especially, these people have got to know just because it's over-the-counter or it's a natural herb doesn't mean it's okay with breastfeeding. So they need to always be always be checking with the pediatrician on what is okay. And then if they do plan on going back to work, we want to teach them about pumping to maintain their breastfeeding, okay? So I tell my moms, if you go back to work, you pump when you would have nursed. So if you're nursing every 3 hours, then you need to pump every 3 hours at work, okay? Save your milk, and they have these really fancy Ziploc breast milk storage bags. They have a place for you to write the date and time, okay? And then we instruct them about storing their saved breast milk. So in the refrigerator, the milk is good for 24 hours. In your freezer that freezes your milk, I'm just telling you this for information, okay? This will not be on the test about how long stuff is what it is, okay? But if your freezer freezes milk, or if your freezer shit. I need more.
Depends on the temperature of the freezer.
Right, it depends on the temperature of the freezer. So if your freezer freezes your ice cream soft, then your breast milk is probably good in that freezer for about 30 days. Okay, this is just an estimate. These are always changing, okay? If your freezer freezes your ice cream hard, then you have about 3 months. If you use a deep freeze, you have 3 to 6 months, okay? And then if you use a commercial freezer like the breast milk bank, I don't know how long they can keep it frozen there, but I think a long time.
Years usually.
A year? Okay.
The limit, yeah.
Uh-huh. So anyways, and then when they take the milk out of the freezer or refrigerator, they look at the date and the time on that they wrote on their little baggie and take the oldest milk first, okay? And then they either thaw it room temperature, which takes a long time, or they can get a container of hot tap water and put the breast milk in the hot tap water. They cannot boil it, they cannot microwave it, okay? They do have fancy breast milk thawing devices. They're just these little devices, and you just dial in there how many cc's of breast milk you have in this container, and you put it in there and you turn it on, and this thing will safely thaw that milk to the right temperature for the amount of cc's of breast milk you have in there, okay?
Can I just say, ideally, you want to thaw breast milk in the fridge, because once it's thawed, you have 24 hours to use it versus
Right.
on the counter or
Right.
in warm water.
Right. So depending, so like if you're a planner and you know you're going to need breast milk for a bottle, get that ready. Or if you're like me, it's time to feed and there's nothing to feed, so you have to pump, or you have to punt. Okay, so weaning. Okay, weaning whenever they want to wean. If that's 6 weeks, 6 years, whatever. So the general guide to weaning is to make it less traumatic on mom and less traumatic on baby, okay? And so we will replace one breastfeeding episode with a bottle or a cup feeding of either breast milk or formula, whichever. And then we'll do that for a couple of days or so, and then we will replace 2 breastfeeding sessions with 2 bottle feeding sessions, okay? Until the baby is completely on either the bottle or real food or in real milk or whatever, depending on when they do this. Now, you can just wake up one day and say, I don't ever want to breastfeed again. Okay, you can do that, okay, but no, you're going to be engorged, you're going to be in pain, and life's going to suck for a couple days. That's why we teach this weaning method, okay? But if she wants to just go cold turkey, she can, okay? Now, that's her. Okay, here's the baby. Okay, what age are we doing this to the baby, and are we putting the baby on formula? Has the baby been eating food? Okay, so if we change baby's diet from one feed and then constantly to the next, we're going to mess up this baby's GI. This baby's going to have constipation issues, pain issues, fever, diaphoresis, crankiness, colickiness, maybe even have decreased urine output because whatever we put them on, they don't want it. Okay, they can't process it. Vomiting issues because we have constipated babies. We're backing up the pipes. Okay, so weaning is the best option, at least for baby. If mom wants to put herself through misery, she can, but please don't do that to your baby. All right, so the slow method of weaning, okay? All right. All right, last one. Any questions? Okay, family at risk. So we're pounding postpartum hemorrhage. Okay, used to be the #1 cause of maternal morbidity and mortality, but now with all of our new protocols and stuff, we're on this a little better. But there's an early hemorrhage and there's a late hemorrhage. Early hemorrhage is the one that happens right after delivery, first day or so. The late hemorrhage can happen up to 6 weeks after delivery. Okay? And the reason why it happens 6 weeks after delivery is there's either a problem with involution or a problem with exfoliation. The other problem that I forgot to throw on there is retained products, placenta, retained placenta products. Okay? What's involution? Does anybody remember? It's the process of the uterus returning to pre-pregnant size. And that also kind of includes exfoliation. I don't know if you guys remember that word. Basically, after delivery, the uterus, those vessels in the uterus, they bleed. So the woman still has contractions or cramping after delivery that compresses those and gets the bleeding under control. The uterus shrinks down. It sloughs off that decidual layer. Okay, so things slough off. That's a part of the bleeding. And then the exfoliation, it's just a special process of where the placenta was attached to the uterus. Okay, so there's super huge vessels in that area. Okay, because it was it was feeding the placenta, and those super huge vessels can continue to bleed. Okay, but we don't want that area. We want that area to heal naturally. And not leave any scarring, because that will be a problem with the next pregnancy. And if that area scars, then that area is unavailable for a future placenta. Okay. But anyways, exfoliation is just the process of the placental site healing and returning to normal. Okay. Here's your early and late hemorrhages. A vaginal birth. Now, these amounts are changing a lot because the amount of blood, so the physician will estimate the amount of blood loss after delivery, and they severely underestimate it. So based on the history of physician estimates, or not just physician, like midwives, anybody who does deliveries, based on their estimates, they've calculated a normal. Okay, but those estimates have really been underestimated. But right now, as the standards say for vaginal delivery, anything more than 500 cc's of blood is a hemorrhage. Okay, and for a C-section delivery, anything more than 1,000 cc's is a hemorrhage. And then repeat C-sections, they have bumped that up to 1,500. Okay? All right. I thought I had this in here, but you might see this again. So when a woman is pregnant, there's 600 cc's of blood volume running through her uterus every minute. So now she's delivered her baby, and until her body realizes she's not pregnant anymore, she's still having 600 cc's of blood running through her uterus a minute. So you can see how this woman could bleed out very quickly right there in front of you, okay? And pregnant women are used to a larger blood volume, okay? And before pregnancy, they were used to a lower blood volume, okay? So now they're bleeding after delivery, and they don't really realize how sick they are until they've lost 1,000 to 2,000 cc's of blood. You don't see anything symptom-wise until she's lost 1,000 to 2,000 cc's of blood. When she's lost 2,000 cc's of blood and you're just now seeing an increase in the heart rate and you're just now seeing a drop in the blood pressure, you're behind the 8 ball, okay? She's going to quickly deteriorate after 2,000 cc's of blood loss, like fast. Okay, poor cardiac output, then end organ dysfunction, and then she's going to start losing her she's going to start getting lethargic, maybe unresponsive, and it's going to happen that fast. Okay, 1 minute you're in there helping her breastfeed, you're changing her pads because she's bleeding a little heavy. Nothing really too alarming. Okay, but then she's going to get to 2,000 and you weren't keeping track. Or the other thing is, she's got a big blood clot in there that's blocking the cervix, and she's just bleeding on top of that blood clot, and you don't even know. Okay, so she's collecting large volumes of blood in her uterus. Okay, so we really need to, that's why we check these women every 15 minutes for the first hour after delivery, is we're looking at how much blood she's putting out. And if we even so much as think she's bleeding too much, we bring in a little scale and we start weighing her pads, okay, so that we can have a quantitative amount of blood loss, okay? And so for all the things we use underneath of a woman, her blue chucks, her pads, all those things, we have dry weights for those on our little postpartum hemorrhage cart. And then for every cc, so you weigh your pad and it weighs, say it weighs 300 grams, okay? And the dry pad only weighed 50 grams. I don't remember. I think it's only 20, but I can't remember. But anyways, for ease of my math skills. So now you have 250 grams of blood. How much does that mean in cc's? For every gram, it's a cc. So you've just had 250 cc's of blood on that pad. And then 10, 15 minutes later, you change another pad that's 250 cc's. Well, that's 500. Okay, so we have a total of 500 cc's out, but the physician has already delivered her and she already had a 500 cc blood loss with the delivery. So now she's up to 1,000, and this is just 15 minutes after the delivery. Okay, so you can see how quick this is going to start adding up. Okay, we also want to be, very vigilant on checking her fundus. That's why her fundus, that firmness of her fundus, and that level of her fundus being at the umbilicus or below is so important. Okay. What's scary is when you have a fundus that's too below the umbilicus, rock hard firm, and you're still gushing blood out of her vagina. Where the heck is that coming from? Okay, what else can I do if I've got a firm fundus, So here we'll talk more, okay? So the biggest cause of postpartum hemorrhage is uterine atony, so you do not have a firm fundus. It's not contracting down. Oh, here's the 600 cc's per minute that perfuses through the uterus, okay? So why are we having uterine atony? Well, overdistension, so she either has more than one baby in there, she either has a big humongous baby in there, or she has a hydramnios where she has what? Lots of fluid, okay? So she has a large uterus. And that uterus is a muscle, so that those muscles have been stretched. Now that we don't have a baby in there anymore, those muscles are just so floppy and stretched. They don't want to contract and get firm. Okay, that'll cause her to bleed. A dysfunctional or prolonged labor pattern, so what that is just an exhausted muscle now. You've been pumping weights for 6 hours, and now you can't even lift a cup of coffee to your mouth because your muscles are so tired. That's exactly what happens with a dysfunctional or prolonged labor. Oxytocin use is pretty much similar, okay? We've caused this uterus to contract, contract strongly and frequently, and there's all these receptors for oxytocin on the uterus, and they're saturated, okay? So now the oxytocin that we're running in and her natural oxytocin is not affecting her uterus. It's like it's shut the doors, okay? You're not coming in. Grand mal tip, similar to the overdistension, someone who's had several pregnancies, that uterus has been stretched several times, and now one of these days it's just like I'm not coming back. Okay, you keep making me work, and I'm not doing it anymore. Anesthesia, why anesthesia? What does your critical thinking say about anesthesia? Close. Relaxation of the muscle. Okay, relaxation of the muscle. Prolonged third stage. What happens in the third stage of labor? First stage is what? Labor. Second stage is what? Baby. Third stage is what? Placenta. So that placenta's been in there, partially or completely disconnected from the uterus, but it doesn't come out, so that's causes more bleeding. Okay. Preeclampsia, operative birth, retained placenta. We talked about retained placenta a little bit. Previa. Asian and Hispanic heritage. So when those people walk in your delivery room, you're going to be all ready. But I'm more ready when a redhead walks in my delivery room. And I'm not kidding you. Redheads bleed. They do. Redheads bleed. All right. Other causes of postpartum hemorrhage, lacerations to the genital tract. So what happens is her cervix has torn, okay? Maybe even part of her uterus is torn. I think uterine rupture is another one. Vaginal wall tears, okay? Those aren't detected by the physician after delivery, so he doesn't fix them, so they keep bleeding, okay? Retained products. If she retains products right at delivery and she keeps bleeding, but sometimes she retains those products, a clot forms, and we don't know it, and she goes about her life, and day 3, week 3, that starts finally releasing now, that clot starts breaking up, and now she's allowed to bleed, okay? Problems with placental implantation, coagulation problems, of course. If your mom has a clotting problem, she's going to have a problem not bleeding after delivery. This just talks about the process of involution, okay, where the uterus is returning to pre-pregnant size, okay? And this is the exfoliation of the placenta and how that site heals, okay? These few slides, they weren't on the main, the main lecture, the main PowerPoint on your Moodle. But they are on the lecture. I added those, and they are on the lecture part. The lecture slides I posted on there. All right, so more about changes. The one thing is, in the hospital, her rubra is going to be red. Okay, she's bleeding, and so it's her lochia. The bleeding is called lochia, and it's red, so it's called rubra. Lochia rubra or rubra lochia. After she's discharged from the hospital, her bleeding will now be pink. Okay, for a couple weeks, a week or two, and then she'll change to white or brown, beige, okay, until she's completely done bleeding. Depending, it could take 5 to 6 weeks, or 3 to 6 weeks. I mean, that says 5 to 6 weeks, but some breastfeeding moms stop bleeding at 3 weeks. Okay, so we're massaging the uterus. We want to keep their bladder empty. Why? What will a full bladder do to her uterus? Displace it and keep it from contracting down. Okay. So we'll watch her urine output, make sure she voids. This is terrible and painful. So medicate your mom. But your physician, if she's bleeding, the physician will actually put his hand in there and do a bimanual compression of the uterus. Okay? Or if we have retained placenta products, then he actually has to go into the uterus and scrape those out while she's laying there on your bed. So please medicate her if her epidural is not running. And then here's the medications we can do for women who are bleeding. Oxytocin, but oxytocin is also a reason why she's bleeding, depending on how much she's gotten. Okay, but we give oxytocin. Methergin is another medication we give. That's an IM injection. You can give, oh, it does show it there. You can give Pitocin IM. So if you've had this woman who comes in with her 4-page birth plan, okay, she's either going to have a C-section or a hemorrhage because she has a birth plan. But she doesn't want an IV, okay? So you can't put an IV in this gal. She doesn't want it. It's on her birth plan. So now she's delivered and she's having a postpartum hemorrhage. Okay, you try to get an IV in, but she's been dehydrated from the labor because she wouldn't let us run fluids, and now she's bleeding, so she has no veins. So you can give IM Pitocin. And Methergin is given IM as well. Okay, Methergin can be given straight into the uterus. So you hand the syringe to the physician, and he just goes straight into the uterus. Okay. And now these are some other medications that we don't usually use, but they are possibilities. Cytotec, that second one from the bottom, that's another big one we use in the hospital. That's given rectally, okay? And the biggest side effect was Cytotec. Is you giving it rectally, and depending on how much you're given, she's going to have some diarrhea. And she's going to be all upset about it, but you got to say, listen, you're breathing, so go ahead. Okay, so.
When at my clinical, the mom that delivered the twins, what did they give to dissolve in her mouth? Was it Cytotec?
It might have been Cytotec. So who was the doc? Was it
Fawcett.
Huh?
Fawcett.
Oh, that's strange. Okay, some docs give it in the mouth, okay, and it doesn't work as quickly or effectively as giving it rectally. So I'm surprised Fawcett went that way. Some of the family practice docs or residents, you know, who don't have a lot of experience will order it by mouth. But I'm not gonna say anything about infections. The one thing I'm going to say about infections is, so we tell moms, so they're at huge risk for a uterine infection just because they had a delivery. The uterus, which is sterile, is now open to the cervix and the vagina, which have bacteria, and then we're shoving our hands up in there all the time. Okay, so she's at, and then we're doing catheterizations. So this woman's at increased risk for infection. Okay, so on discharge, I'm telling this woman we got to know about fevers. We got to know about pain that's not controlled. So your pain is under control right now. You're taking an ibuprofen every 8 hours or so, and you're doing just fine. And you get home, and your ibuprofen is not helping your pain. That's a big red flag for a uterine infection. Okay. And the other thing is foul-smelling vaginal discharge. So women are embarrassed to say, I stink. Okay. Yeah, it does have an odor. Okay, normal odor, but I'm talking foul-smelling odor, okay? So she's embarrassed and she doesn't want to tell anybody. She thinks she's dirty, so she doesn't say anything. Okay, that's an infection. So I tell her, it's okay, it's not you. You have an infection and you need antibiotics, okay? So that's all I'm going to really say about infection. You can read over these slides. I just want to save time. And okay, so I'm just trying to save time to go over the exam. Do people want me to go over the exam? Okay, so let's, so all this is about infection, infection. Okay, so you guys can read over these. These are pretty straightforward. Oh, there's mastitis. Okay, so, oh, thrombosis. Oh, I do want to say thrombosis. So, have I said that pregnancy is a hypercoagulable state? Okay, so one of the reasons why is this venous stasis. So we have the weight of this big old uterus on our iliac vein there, and so it causes a little stasis or prolonged emptying in the lower extremities. Okay, so that's kind of normal. Okay, so we need to watch for. Okay, so you guys can read through this. Okay, so this is really straightforward stuff here. So when you assess when you assess for DVTs, do you guys do Homans? Okay, it's still running around in the literature on occasions, but don't do Homans. Why? Okay, so you can do other things to assess for a clot. They have pain in their calf, red, swollen, fever, edema, all these kind of things. Okay, treatment is Lovenox. These women may be on Lovenox during pregnancy and after pregnancy, and then if they're in labor, they're on a heparin drip. Okay, they could be on Coumadin. Okay. All right. All right. So let's go over the test. Now I gave. It's squinting. If any of you have noticed, there were 5 questions. Well, you don't know that. There were 5 questions on the exam that more than 50% of the class missed. Okay? And I gave you, whoever missed those, I gave you full credit for those questions. And those are definitely those are definitely ones I want to go over. And if you have additional ones, then let's talk about them, okay? So, come on, buddy. A community nurse is working with a patient at 32 weeks gestation who has been diagnosed with preeclampsia. Which statement indicates that additional information is needed? Okay, I should call the doc if I develop a headache or blurred vision. Is that legitimate? Okay, so that's not the correct answer because it's one of those tricky ones. Lying on my left side as much as possible is good for my baby. Is it?
Yes.
Yes. Pain at the top of my abdomen is a sign of my worsening, my condition is worsening. Is that correct? Right. So my urine may be darker and smaller in amount each day. Is that correct? Okay. Why is that not correct? Doesn't preeclampsia affect the kidneys? Eventually. It's called eclampsia. But of all those, are all those legitimate? All those possibilities are legitimate. Okay, which ones are the worst? Okay, so these 3 are the worst. Okay, these 3 are worsening of her preeclampsia. This is worsening of her preeclampsia as well, but not as critical as the other ones. So that's why I gave it back. Okay, I don't know, 13 people missed this question. So it's a really bad question. Yeah, 13 people missed this question. There's only 18 in class, so. That's not really a problem in preeclampsia, urine output, okay? And darker is not so much an issue either, okay? So that's why, okay? So I gave that. All right. The next one, 10 people missed this one. I don't know if that's a privacy thing. I'm being bad. I don't know. A health nurse is admitting a patient at 18 weeks who is pregnant with twins. Which nursing action is most important? Collect a fetal fibronectin.
No,
What is a fetal fibronectin? Does anybody know?
it's for neurotube.
No, fetal fibronectin is a test that they do to see if she is likely to deliver in the next 2 weeks. Likely. So she can have a positive fetal fibronectin. That does not mean let's admit her because she's going to deliver. That just means she is likely to deliver. Okay? Teach the patient about foods that are good sources of protein. That's a good answer. Determine whether the pregnancy is a result of an infertility treatment. Okay? Assess the woman's blood pressure in her right upper arm. Okay, we're admitting a patient. Are you going to check vital signs? Yeah. So this is the reason why I gave this back. Teach the patient about foods is the correct answer. But if I'm admitting a patient, I'm going to get them in the bed, I'm going to orient them to the room, I'm going to check their vitals, I'm going to put her on the monitor. Oh, she's 18 weeks. Okay, so I'm going to be doing those things. And I am going to teach her about good sources of protein, but this is why I'm giving this question back, because I don't like it. And, you know,
I think the rationale is that because it doesn't have to only be the right arm. I thought that was
Yeah.
a cheap
Oh.
answer.
okay.
Yeah.
Yeah, it doesn't only have to be, yeah. That's ridiculous. That is ridiculous. Okay. 27. 11 people missed this question. Okay, the laboring patient has experienced spontaneous rupture of membranes. The fluid is meconium stained. Is that good?
No.
The heart rate is 100 to 105. Is that good?
No.
What is that? Okay. Which nursing action is most important? Change mom's position to Fowler's, from Fowler's to left lateral. Okay, we might do that. Notify the surgical team of an impending C-section. Why?
That's a medical decision.
Okay, one, that's a medical decision. We can't do that. However, there's nothing here in her description that says we need to go to C-section. Nothing there. Okay. Okay. Decrease the IV fluid. Huh. Insert a Foley, a catheter, with the assistance of another nurse. Right. I mean, we may insert a Foley catheter, but that's not the most important thing to be doing right now. What's the most important thing? Change her position. The first thing you do when baby's crumping is you change the position. Every time, the first thing you do is change the position. I'm going to say that because there was a question on somewhere, some question somewhere, I don't know if it was your class or the other class, but mom was crumping. Baby was doing fine. And the first thing, one of the answers was change mom's position. One of the answers was her blood pressure was in the toilet. One of the thing was give a fluid bolus. Okay, what was the correct answer there? Huh? Fluid bolus. Why did we change her position first? It wasn't a baby issue. Okay, it was a mom issue. She was circling the drain at whatever her blood pressure was. So we need to keep her alive to keep the baby alive. So putting a hypotensive patient on their side, not necessarily going to do anything to their blood pressure. We need to get that blood pressure up. Okay? But anyways, if it's a baby issue, first thing you're going to do is change your position. Okay? What number did I say that was? 27? Okay, 37. Okay, the nurse is completing discharge teaching for a patient who delivered 2 days ago. Which statement indicates that that further information is required? Because I have a midline episiotomy, I should keep my perineum clean. Yeah, right. That's right, you should. The tear that I have through my rectum is unrelated to my episiotomy. Okay, so what's an episiotomy?
It's cutting.
The physician cuts. Does a physician cut into the rectum?
No.
No. Okay, he doesn't cut into the rectum. So why does she have a tear in her rectum? It kept going. He cut the episiotomy, he started to deliver the baby, and the tear kept going. Okay? I can take ibuprofen when my perineum starts to hurt. Yeah? Yeah? Soaking in the tub will help my medial lateral episiotomy to heal. Okay, so this is another reason why I'm giving this back, is there is some confusion on whether someone with an episiotomy can actually sit in a tub, because isn't that a source of infection, sitting in a tub? Okay, so that is correct. She can sit in a tub and soak her episiotomy. Yes, sitz bath has been the norm for some umpteen thousand years, but that's old school now. We're fancy. We get in a tub. Okay, so this is why I'm giving this question back. The correct answer was the tear I have through my rectum is unrelated to my episiotomy. Okay, so yeah, it's definitely related to your episiotomy. This is why it's confusing, because a student will look at that and say, episiotomy isn't a tear, so this is incorrect. Okay, but what happened here is he did cut an episiotomy and it extended. It tore on its own from the end of the episiotomy to her rectum, and so that's what it is. So it was a trick, and I gave you credit for that. Okay, and number 39 is the last one that I was concerned with. A patient had a classical uterine incision. Which way is that? Okay. The nurse knows that the patient understands implications for future pregnancies that are secondary to her classical uterine incision when the patient states. Okay. The nurse knows that the patient understands. Okay. Every time I have a baby, I will have to have a cesarean section. Does she?
She doesn't, the risk is higher.
She has to have the cesarean section. A classical incision, which you guys said, was top to bottom. We cut through the entire length of that uterine muscle. Okay? So when that uterine muscle contracts in her next labor, it's going to blow that incision. Okay? If her incision is down here, straight across horizontal, she can try for a vaginal birth, okay? Because it's just right down here. The strength and the bulk of the contracting is happening up here, okay? The risk of rupturing my uterus is too high for me to have any more babies. You can still have babies. It's not so much, I mean, that is a really rare risk that growing a uterus is going to blow that scar. But the problem with the scar is the contracting, okay, and blowing the scar, okay. The next time I have a baby, I can try a vaginal delivery. No, we already said that. I can only have one more baby. No. The patient knows that. What's the question? These screw me up too. The nurse knows the patient understands. Every time I have a baby, I have to have a cesarean delivery, so this is the first answer. Okay. Does anybody have any questions that they would like reviewed? Do you want me to try to hit the whole test?
So out of curiosity, if they did a classical C-section, would the following also have to be classicals?
Usually they do, just to prevent another scar.
And then do they cut along the same line? Do they cut next to it? Like how?
So I think what they try to excise the old incision, especially if the one on the outside of the body is really gory looking. They'll try to excise that. So it would be easier to go like right beside than to cut through an actual scar, and then the other side. Okay. The scarring on the actual uterus is not as dramatic looking as on the skin of the belly. Okay. Have I ever told you my anchor stories? Have you ever heard an anchor story? So we've done a C-section on a woman. It was not an emergency C-section. So we did the horizontal cut. They got in there. Whatever happened went south, and they needed to get the baby out. It's very hard to get the baby out here. They cut a very little hole, and the physician sticks his hand in that hole, and he hooks kind of under, the skull bone, okay? And he doesn't want to just pull that out because he can hurt the baby's spine, okay? And there's kind of like a suction-y type going on. And so the other person that's gowned and sterile pushes on the woman's fundus. And as he's pulling, she's pushing, and we deliver this baby, and it's in a really tight hole, okay? And sometimes they've had to put forceps in there to get the baby's head to come this way. Sometimes they've had to put a vacuum on the baby's scalp to kind of help pull this baby out. And I'm thinking like, dude, like, you've already cut 4 inches of her belly, cut another inch. Gosh, get this baby out. So they cut such a small hole, and whatever happens, they're having trouble getting the baby out. And it's now, for whatever reason, going critical, and then so they go like this. They cut right up the abdomen and flay her open and pull the baby out. And when you cut that way, you can just lift the baby out, like you're lifting the baby out of a crib, okay? That's why they do a classical C-section in an emergency. It's the fastest way to get the baby out. But that's an anchor, so she has an incision straight down her belly and an incision horizontally. That's called an anchor, and I've seen it a few times. And one of the times I've seen it was on my sister's sister-in-law. It's really, really tough. Like, I'm the nurse, she's kind of family, and I'm sitting there, and I'm like, come on, doc, get the baby out. And faster. Cut her.
So how does that affect future pregnancies then?
All C-sections, she can still be pregnant, she can still have children, and she did. So that's fine, but that's called an anchor. I don't know if that's in the textbooks as a legitimate C-section procedure.
Mom has a prolapse cord, and you know how the nurse is to hold pressure. Do they keep the pressure during the C-section, or does the nurse release?
No, they keep the pressure until the physician pulls the baby out. So she's under the drapes. Josh, did you have any questions about specific questions on the last exam?
No.
I gave 5 questions back, so everybody's grade was adjusted. Okay. Oh, okay. So tomorrow I'm coming to Missoula, and I will have a review session tomorrow for the last exam. Okay. If you want to throw out some times, if you would like to come, you may come. If you do not want to come, you do not have to come.
So if we've got the conference tomorrow, will you record the review?
What conference?
We're going to a pediatric conference at
Oh.
Holiday Inn,
What time is that?
8 to 5.
Oh, yeah, I'm not gonna be here after 5.
Then you have a path exam.
I can record it if you would like.
Yeah, we probably-
All of you are going?
No, we have a
path
Okay. Well, I do have some people that want that, so we're going to do that and tomorrow, and I will let you know the time, and if you want to come, you can. I will go ahead and record it.
So you'll just email us the time?
Yeah, I'll just email you the time.
Great, thank you.
All right.
And then we have our test on Tuesday.
So you have your test. Okay. Oh, we got ATI today. I almost forgot. Let me turn off the recording.